Hello, my name is Anthony DeRoss, and I am a pediatric surgeon at the Cleveland Clinic in Cleveland, Ohio. And today I'll be talking about common problems in pediatric surgery. First, I have nothing to disclose. And just to give an idea about the format for the lecture, I've arranged it into case presentations to kind of keep it interesting. It has to do with many common problems that we see in pediatric surgery that have a specific nature related to pediatric surgery that we find both interesting and important for people to understand when these patients with these problems are encountered. I then have some questions about some of the cases to at least stimulate some thought about the diagnoses, and then some detailed didactic information that follows. So the first case is a 3-year-old term male who's discharged home after 48 hours of life. He's feeding well initially, but then develops vomiting, which was first just formula, but then becomes bilious. He passes a small amount of meconium for the first time today, which is day of life 3. On exam, he appears distended, has a normally positioned anus with normal tone, and passes a large amount of meconium with rectal exam. A KUB shows dilated loops of bowel. So the first question, this diagnosis is most suggestive of A, malrotation with midgut volvulus, B, ileolatresia, C, distal intestinal obstruction, D, necrotizing enterocolitis, or E, constipation from formula intolerance. And the answer is C, distal intestinal obstruction. That's the correct answer, although some of these could be considered. There is a large amount of dilated bowel that seems to be gas-filled on newborn plain films. It's difficult to tell whether it's small or large bowel because the colon doesn't have its normal Haustroll markings. And all we can see is there's a lot of air-filled bowel here, so it's probably some sort of distal obstruction that you wouldn't see with malrotation with the midgut volvulus. Could be an ileolatresia, I suppose, but really more generically, distal intestinal obstruction. Probably not necrotizing enterocolitis, and certainly not constipation at this early age. Proper management includes immediate laparotomy to relieve obstruction, XLAP after fluid resuscitation and antibiotics, change to soy formula, and return to the office if the fever develops or there's more vomiting, contrast enema, or small bowel follow-through. And contrast enema is the best answer. In this case, anytime there's concern for an obstruction in a stable patient, as this patient seems to be, it's better to do a contrast study from below rather from above, so that the contrast, if it were administered from above and there were a distal obstruction, that contrast might linger for quite some time, which would make it difficult to do a lower contrast study. So we usually do the lower one first, and then if that's negative, follow with a contrast enema or a contrast study from above. So here's the results of the contrast enema. You can see this is the rectum and going more proximally into the more proximal rectum and sigmoid colon. So the contrast, the barium enema shows pneumatosis, a transition zone in the sigmoid colon, a rectal stricture, normal colon, so maybe a proximal obstruction, or colonic atresia. And this really it's a little hard to tell on this radiograph, but this is the sigmoid colon much more dilated than the rectum, and that is abnormal. Usually the rectum is more capacious and distendable than the sigmoid colon with an enema. So this is really indicative of a transition zone in the sigmoid colon. The next step in management is descending colostomy, 1-stage pull-through procedure, bedside rectal biopsy, full thickness operating room rectal biopsy with frozen section, or A and B together. And the proper answer is bedside rectal biopsy. If in a patient with this diagnosis suspected, the best next step is to perform a bedside rectal biopsy, which is very easy to do in a newborn patient. And we'll talk a little bit more about that. Once the diagnosis is confirmed, management might include ileostomy, descending colostomy, immediate one-stage pull-through, daily rectal irrigations with delayed surgery, or B, C, and D. Really, B, C, or D could be considered in a patient with this diagnosis, which I will tell you. An ileostomy could be considered, but probably given the contrast enema findings with the transition zone in the sigmoid colon, probably an ileostomy would not be necessary. The aganglionic bowel, which is the hallmark of this disease, must be resected, bypassed, resected or bypassed, preserved for later use and reconstruction, or stripped of its muscle layers. So it can be resected or bypassed depending on the patient's status, and we'll talk about that. The procedure with the lowest incidence of post-op complications is a Duhamel, Swenson, Suave, any of the above with a laparoscopic versus open approach, or none of the above. None of the above. All of these procedures have similar post-op complications, and in the hands of a surgeon who performs any one of them routinely, the complication rates are really equal. We'll talk a little bit more about that. So the patient undergoes definitive correction without complications and is then home, tolerating a regular diet, having normal bowel habits. 4 months later, he presents to the emergency room again with a fever to 39 degrees centigrade, lethargy, watery loose stool, and abdominal distension. The management now includes admission for rectal irrigation and IV antibiotics, admission NG tube, antibiotics and bowel rest, stool cultures and oral flagyl, Tylenol, clear liquids, and instructions to return for continued fever or dehydration, or barium enema to rule out stricture. This is a diagnosis of enterocolitis until proven otherwise with those symptoms in a patient with this disease, and this needs to be treated aggressively with admission, rectal irrigations, and broad spectrum IV antibiotics. Choice B also is kind of correct, but really the rectal irrigations are crucial to help clearing out and decompressing the distal bowel. And this disease is associated with the Vactal Association, Beckwith-Wiedemann syndrome, Down syndrome, or an autosomal recessive inheritance. And it's often associated with Down syndrome in up to 16% of cases. So this is no surprise to anyone at this point, is Hirschsprung's disease. First characterized by Harold Hirschsprung. He was the first Danish pediatrician in 1870, and then described the disease named after him in 1886. But when he described it, he believed that the proximal dilated bowel was the diseased bowel, and it wasn't until 1948 that others, and then Swenson, who was a pediatric surgeon in Boston at that time, performed this first successful pull-through procedure, realizing that the distal normal caliber bowel was actually the abnormal bowel and had to be removed. So Hirschsprung's disease, 1 in 5,000 live births are affected by Hirschsprung's disease, and 60% of those cases are discovered in the neonatal period. It's due to an absence of ganglion cells in the bowel wall with the inability of the affected bowel to relax. 80% or more of these cases are in the rectosigmoid region, but they may involve the entire colon or the small bowel, which is, or up into the small bowel, which would be long segment Hirschsprung's disease, or it could be limited just to the distal rectum, which is short segment. It's a 4-to-1 male to female predominance for rectosigmoid Hirschsprung's, which is the most common, but really more of a 1-to-1 ratio once you get into patients who have long segment disease, and only about 10% of these patients are premature. So uncommon in premature infants who themselves take a while to have a bowel movement after birth. We know that it's related to the Rett proto-oncogene. In about 50% of familial cases of Hirschsprung's disease and about 20% of sporadic cases can have a defect in the Rett proto-oncogene, which incidentally is also the gene that can be identified in patients with MEN type 2, multiple endocrine neoplasia type 2. And so it's important to watch for the development of especially medullary thyroid cancer in patients with Hirschsprung's disease. And there are some recommendations now to screen patients for MEN susceptibility when they do have Hirschsprung's disease. So something we didn't do much when I was training, but it has become more important now. The Rett protein is a receptor tyrosine kinase, and in mouse models, it's been found to be necessary for the migration and survival of enteric neurons. And that the degree of aganglionosis seen in mouse models is proportionate to the Rett dosage. So this is what we see for the distribution, the typical distribution of Hirschsprung's disease. Up to over 70–80% of cases are in the rectum, sigmoid, and descending colon, and then it becomes much less common for it to be involving the proximal colon and very uncommonly the small bowel, but it can involve any length of bowel. We know that the enteric neurons migrate from proximal to distal, and so wherever they stop migrating, that's the level of the Hirschsprung's disease, where distal to that, there's an aganglionic segment. Proximal to that, there are proper ganglion cells. There's kind of a transition zone in that area where the two segments meet, and that's where we see a gradual dilation of the bowel starting to happen. Infants, when they have Hirschsprung's disease, will present with progressive abdominal distension and then sometimes bilious emesis, which is a sign of obstruction. They have a failure to pass meconium in the first 24 to 48 hours of life, and that's a key component in the history. 95% of normal babies will pass meconium within the first 48 hours of life, but 60 to 90% of Hirschsprung's babies will not. So very abnormal for babies not to pass meconium, but up to 40% of patients with Hirschsprung's disease will pass meconium. So it's not a hard and fast rule, but whenever they do not pass meconium, babies should be people should start to think about the diagnosis of Hirschsprung's disease. 10% of babies will actually present with severe enterocolitis at the outset prior to diagnosis. And that can be a life-threatening problem, which we'll talk about more. Rectal biopsy and contrast enema, not in that order, are the hallmarks for diagnosis. Rectal biopsy will show an absence of ganglion cells, and contrast enema may show a transition zone, which is important not only for diagnosis, but also for surgical planning. This is how patients used to be diagnosed with Hirschsprung's disease, where they would present with a huge megacolon when they were toddlers or even older, because it would go undiagnosed for such a long time. The descending and sigmoid colon, most often affected, would be very dilated, and patients would have a very protuberant, distended abdomen. A normal contrast enema, again, shows dilation of the rectum with the sigmoid and then descending colon being of a more narrow caliber, and this is normal. This is reversed because patients often have this test done when they're in the prone position. But in a patient with Hirschsprung's disease, the rectum doesn't dilate and looks to be about the same ratio or the same caliber as the descending sigmoid colon. You can see the transition zone up here where the proximal descending and transverse colon are very dilated, and this is very typical of Hirschsprung's disease. Again, failure of the cranial to caudal migration of neural crest precursors between weeks 5 and 10 of gestation, and that involves ganglion cells within the Meissner plexus in the submucosal layer of the bowel, as well as the Auerbach's plexus, which is between the circular and longitudinal muscle layers of the bowel. And this is important in the way that we diagnose Hirschsprung's because of the way we do our biopsies. Suction rectal biopsies will biopsy the mucosa, so we're looking for that more internal layer of ganglion cells, where we have it doesn't look quite like this anymore. There are newer models, but it still is the same idea. There's a small chamber within the end of a suction device that allows some mucosa to be drawn inside, and then a small blade will come and shave a piece of the mucosa off and this is done above the level of the dentate line where there are no sensory nerve cells in normally, and so it's a painless bedside procedure that can be done, in the nursery or in the office for young patients. Usually, once they're about more than 3 or 4 months of age, that rectal mucosa becomes a little too thick to do this way, and we have to do an open biopsy instead, where we actually will take the patient to the operating room and with some exposure get a strip of the mucosa and submucosa to send as a more permanent specimen to pathology. Once we make the diagnosis of Hirschsprung's disease distally, then we still don't know how proximal the level goes. And we'll take patients to the operating room at the time of surgery, and we'll do what's called a leveling biopsy, where we take biopsies of the serosa, this time doing that biopsy between the circular muscle layers, looking for those ganglion cells instead of the mucosal ones. And we'll do biopsies up along the bowel, past any apparent transition zone, to get an idea of where the ganglion cells are present, revealing the normal bowel. So this can be done in the stage procedure, where we do leveling biopsies and then a colostomy, and allow the patient, if they're sick, if they have enterocolitis, if we're not sure about the transition zone, if we don't trust the frozen section pathology for some reason, we can always do a colostomy above the level, and then and in the worst cases, an ileostomy if we're worried about long segment Hirschsprung's disease, allow the patient to grow and then come back and do the definitive pull-through procedure. Or it can be done in a one-stage pull-through procedure with either laparoscopic assistance or just transanally if we're confident that it's a low transition zone. We basically, all of the different types of surgery for Hirschsprung's involve removal of the aganglionic segment. We anastomose the ganglionated bowel to the anus. We want to make sure that it is ganglionated bowel and that our pathology is correct. We want to avoid injury to the pelvic nerves and the urinary tract structures as we do so. So here's just a cartoon showing the different types of procedures. Swenson's original procedure is basically like a low anterior resection, where basically all of the aganglionic bowel is excised to full thickness, and the ganglionated bowel is brought down right to the anus, and a coloanal anastomosis is constructed. The Suave modification involves development of a muscular cuff. So there's a submucosal dissection that's done distally, and this cuff is left behind, and that's to avoid injury to the surrounding structures. The cuff is split posteriorly so that it can't be constricting once the normal ganglionated bowel is brought down for the coloanal anastomosis. And then a Duhamel procedure is sort of a side-to-side stapled anastomosis, where the aganglionic bowel is allowed to remain anteriorly, again allowing preservation of the pelvic nerve structures as well as the urinary structures anteriorly, and the aganglionic bowel is brought down. And this is a procedure that's often reserved for redo procedures or for patients with long segment Hirschsprung's, because it allows for basically a little bit more of a reservoir to be created, sort of a neorectum. Here's just a quick video that I'll just show, and I'm going to cut through because it's a little bit too long. But this is a neonate with Hirschsprung's disease. You can see here, this is a low segment. This is the transition zone right here. This is the distal rectum, and then the dilated rectosigmoid above the level of the peritoneal reflection. You can see that it's tough. There's not a lot of domain in these small patients. These are 3mm instruments, so everything is very tiny. But that transition zone is very easy to see right away. And as we try to run the bowel a little bit and look for any other evidence of disease, you can see as we skip ahead, we try to make sure that we identify the ureters on both sides. They can be very easily injured, and they're easy to see in patients of this age because all of the tissue layers are so transparent. There's the left ureter there as we're retracting the sigmoid colon anteriorly, and here we're starting to dissect the rectosigmoid mesocolon, And as we continue to do so, we make an opening there. We've preserved the IMA pedicle in this case because it is pretty short segment. And then we continue our dissection distally down to the level of the pelvic floor. And once that's complete, we turn our attention to the anus, where we retract the anus open to expose the dentate line. We make an incision in the mucosa several millimeters proximal to the dentate line, and then do our submucosal dissection for 1 to 2 centimeters before entering the peritoneal cavity full thickness, and then removing the immobilized specimen, which is then, and you can see the transition zone. This is an older patient with the specimen, but then just for illustration purposes, but then we're able to construct the coloanal anastomosis at the level of the submucosal dissection, and then the hook retractor is removed and the anus is allowed to return to normal. And these patients, we use 3mm instruments, so that's one trocar site, and then there's a camera trocar in the umbilicus, so they have really very little scarring associated with it, and they tend to do very well. 70% will have a good outcome with near normal bowel habits. 15% will have some degree of sometimes severe constipation and need to be managed with a chronic bowel regimen. 15% will have chronic diarrhea, and those patients sometimes need to be managed with a bowel bowel regimen that allows includes Imodium to try and help them to have clean intervals in between so that they can function. And then 10% will still develop enterocolitis even after a pull through. And need to be watched, especially in that first year of life. And outcomes can be much worse for patients with long segment disease. So, but that's Hirschsprung's in a nutshell. Moving on, case number 2, a healthy 1-week-old term infant who was previously well presents with 24 hours of vomiting, decreased bowel movements and urine output, and lethargy. The last stool was partially formed and streaked with blood. On exam, the infant is dehydrated and lethargic. The abdomen is scaphoid, soft, non-tender, and rectal exam shows a normal tone, but there is some blood-tinged stool. Labs are remarkable for mild leukocytosis of 16. There's a little bit of a metabolic acidosis with a low bicarb of 17. And this is a picture of the patient after they've had some emesis, which is really, really dark green. X-rays show dilated stomach and a little bit of proximal dilated duodenum. So the most appropriate test in this case is, if you're going to get a test, you might argue this patient might need to go straight to the OR with these findings, but Doppler of the superior mesenteric vessels, contrast enema, upper GI, or CT scan. I know you're all thinking upper GI, that's correct. In this case, and we'll talk about why that's correct. And the upper GI shows this. Here's the stomach, and then basically duodenum and some spiraling of the bowel down on the right side of the abdomen. Thinking about this diagnosis, normal fetal intestinal rotation occurs between the 6th and 10th weeks of gestation under the influence of maternal hormones within the peritoneal cavity of the fetus, or between the 10th and 16th weeks of gestation. Pretty early on, between the 6th and 10th weeks of gestation. Normal intestinal rotation involves 180-degree clockwise rotation of the cephalic loop around the celiac axis, a 270-degree counterclockwise rotation of the duodenal-jejunal loop around the SMA, 270-degree clockwise rotation of the duodenal-jejunal loop around the SMA, or a 360-degree counterclockwise rotation of the duodenal-jejunal loop around the SMA. The answer is a 270-degree counterclockwise rotation of the duodenal-jejunal loop around the SMA, and we'll talk more about that. Clinical presentation of malrotation includes acute midgut volvulus, chronic duodenal obstruction, failure to thrive with feeding intolerance, or all of the above. Right, all of the above. 30% of patients with malrotation will present within the first month of life. True or false? That's false. We'll talk about the presentation. And the operation for malrotation is A, not indicated for asymptomatic patients, B, should not be undertaken until the diagnosis has been confirmed by contrast radiology. C, consists of laparotomy, reduction of volvulus, release of Ladd's bands, and cecopexy. Or D, may require a second look procedure. And D, may require a second look procedure in cases of bowel ischemia. Post-op complications include recurrent volvulus, adhesive intestinal obstruction, short bowel syndrome, or all of the above. That's right, D, all of the above. All right, so obviously no surprise again, intestinal malrotation and midgut volvulus, one of the true pediatric surgical emergencies. It has to do with an abnormality in the development of the midgut, which is itself usually characterized by rapid elongation of the primitive bowel and its mesentery, which forms the primary intestinal loop. So right at 6 to 7 weeks, this primary intestinal loop grows. This little outpouching is the vitelline duct, which can be, if it remains, usually regresses, but if it remains, becomes a Meckel's diverticulum. But you can see stomach, all of the small bowel, where the midgut really develops around the distribution of the SMA. As the primary intestinal loop herniates into the umbilicus because it's growing faster than the abdominal cavity will allow, it rotates around the axis of the SMA 90 degrees counterclockwise as it would be viewed anteriorly. And then as it returns, it rotates an additional 180 degrees counterclockwise for a total of a 270 degree counterclockwise rotation, which gives us that normal C loop anatomy of the duodenum. And we can see with patients with normal rotation, there are multiple fixation points for the bowel. There's a fixation point here at the ligament of Treitz, a fixation point down at the terminal ileum. The ascending colon is pretty well fixed in position. The transverse colon is more mobile, but we're fixed at the hepatic and splenic flexures, and then the sigmoid colon and distally at the rectum, things are fixed. And the mesentery here is nice and broad. If you stretched out the mesentery completely, you'd see it forms a nice diagonal line from the ligament of Treitz down to the ileocecal valve. In patients with malrotation, that doesn't happen, and they have the mesentery is not only mobile, but there's a very narrow mesenteric base, which you can imagine is very predisposed and at risk for volvulus, because especially given the weight of the bowel distally. The Ladd's bands are the bands that would probably normally anchor the cecum in place down in the right lower quadrant, but because the cecum isn't there in patients with malrotation, you can see the cecum can be up here. Those bands will sometimes still try to find it, but instead of just coming from a short distance from the abdominal wall, they'll cross over the duodenum, and it's this part of the Ladd's bands which are involved with the proximal duodenal obstruction that can be seen with malrotation. So malrotation is characterized by patients who have incomplete rotation. There's a short mesenteric base and obstruction, both from Ladd's bands, which cross the duodenum, as well as from, in some cases, extreme cases, the midgut volvulus, which patients with malrotation are predisposed to getting. So here's a patient who had malrotation with volvulus. You can see it actually looks a lot worse in this picture than it did in real life, but this is the normal healthy colon, but this is basically a triple twist of the bowel, which has caused some ischemia. As soon as we were able to untwist that, the bowel pinked up and was healthy again. Ladd's procedure is named after Dr. Ladd, who's one of the forefathers of pediatric surgery in North America, and the Ladd's procedure is named after him and doesn't stand for these steps, but you can think of it to help remember the steps of a Ladd's procedure by thinking of these steps, which aren't in the proper order, but basically the first thing you would do would be this D, which would be to devolvulize or untwist the bowel in a counterclockwise manner. It's always counterclockwise, and but you would, just in case, you would make sure that you're untwisting it properly. But it's like turning back the hands of time. So you're turning back the hands of time. You're twisting in a counterclockwise manner to untwist that volvulus. The next thing you would do is divide the Ladd's bands over the duodenum. You don't necessarily have to cochorize the duodenum, but you want to really relieve any evidence of obstruction by dividing those Ladd's bands if they're present. Then we do an appendectomy, probably more of historical significance, but patients who undergo a LADS procedure are pretty much expected to have had an appendectomy, so we do it to avoid confusion. It also may give a little bit of an additional point of fixation, which will help keep patients from having a recurrent volvulus theoretically. But historically, we removed the appendix because who knows where the appendix would be later if the patient were to develop appendicitis. Now that we have CT scans, probably it would still be pretty easy to find the appendix. But appendectomy remains a component of the LADS procedure. And then we try to broaden the mesentery as well, where we divide the peritoneum along the axis of the SMA so that really the mesentery can unfold. And I always think of it like a fan that one of the fans that's folded that can be then unfolded so that one can hold it in their hand and fan themselves. I always think of the mesentery unfolding like one of those fans when we divide the peritoneum overlying it to then broaden the mesentery. So L, lengthening or broadening the mesentery, A, appendectomy, D, dividing LADS bands, and D, devolvulizing or untwisting the bowel. So how common is malrotation? We know that up to 0.5 to 1% of patients asymptomatic at autopsy have some degree of malrotation. So it's pretty, fairly common when you think about it, and oftentimes probably not symptomatic. But when the incidence of symptoms lead to its discovery, it's estimated to be about in 1 to 6,000 live births. And when do patients become symptomatic? Well, like we talked about in that one question, 30% by 1 week of life, 50% by 1 month of life, and then usually 75 to 90% by 1 year of life. So most of these patients are diagnosed early in life because of their symptoms. There are some patients that go on to develop complications of malrotation, and one of the more famous patients to die from complications of malrotation and volvulus was Maurice Gibb, one of the Bee Gees. Some of our older surgeons watching might remember him. So malrotation and volvulus, they're two different conditions. Malrotation is the anatomic abnormality that predisposes patients to having midgut volvulus, and midgut volvulus is the surgical emergency that arises because intestinal blood flow is compromised in those cases. Here is an upper GI showing malrotation without obstruction. You can see the stomach on one side on the left, and then all of the small bowel really on the right side of the abdomen instead of being more evenly distributed, and you don't see that normal C loop of the duodenum. At surgery, if a segment is ischemic, you really want to try to preserve as much bowel as you can. So if there's any question, you can always plan a second look operation in 24 to 48 hours. We try to leave any questionable bowel in place just in case it recovers. If the patient is stable and if it's more of a segmental volvulus, then immediate anastomosis can be done if it's just a short segment, and then delayed repair if they're unstable. If the entire midgut is necrotic, then those patients often are in a terrible situation where they're oftentimes extremely acidotic and sick and difficult to resuscitate, and oftentimes will not recover from this surgery. If one consideration is not to do any resection and to institute comfort measures. And it's extremely hard to have this conversation with a family, sometimes in the middle of the night when you haven't met them before under emergency conditions, but to talk about the possibility of resecting the bowel and then hoping that they can be a transplant candidate down the road. You're really embarking on a road that is full of hurdles for many, really for a lifetime. So it's if you're at a center that can support small bowel transplant, or even keeping the patient on TPN for a chronic period until they're a candidate for transplant, that's something that can be considered in a case-by-case basis. But it's important to just to understand that when this situation is encountered, some of those discussions, when there is entire midgut necrosis, those discussions can be very difficult. And it's important to know what resources are available in your institution or your area of the country or world. One important point is that cecopexy is not indicated. A lot of old teaching was that the bowel needed to be put back in the proper orientation, the proper anatomic normal orientation, and really you want to just end up with really this orientation where the small bowel is on the right and the colon is on the left. Performing a cecopexy has been shown to increase the risk of complications, mainly of bowel obstruction or recurrent volvulus down the road, so it's not indicated. Laparoscopic LADS procedures, somewhat controversial because one of the reasons for doing a LADS procedure, in addition to reducing volvulus, is to hopefully create some adhesions so that the bowel is more fixed in position so it doesn't twist upon itself. And with laparoscopy, we traditionally have understood that there are fewer adhesions. So for that reason, it's somewhat controversial, but in patients who are stable, who have incidental malrotation noted on other studies, we'll sometimes do laparoscopic LADS procedure, and it is effective. There's a less than 1% incidence of post-op bowel obstruction in those patients, but probably a 3.5% incidence of post-op volvulus. So they're still at risk for volvulus after the procedure. That's in contrast to an open LADS procedure where there's a much higher 10% incidence of bowel obstruction, but really half the risk of post-op volvulus. So, what's worse, bowel obstruction or volvulus? That's something that each surgeon can answer for themselves, but it's important to be aware of the potential complications and recurrence rate, no matter which procedure you choose to do. All right, case number 3. 2-year-old male who's been inconsolable now for 12 hours, had a viral upper respiratory tract infection last week, curling up with pain episodes, but then falls asleep in between, was vomiting some formula and food, but then green and yellow emesis after that. Stool has been red and mucousy, and on exam, the patient is afebrile, has a really soft, non-tender abdomen. X-ray shows this. And this is actually a patient I had that had this problem. This is an extreme example of an X-ray, but anytime you see air fluid levels and loops of bowel that look like question marks, that's usually a bad sign. So definitely some dilated loops of bowel, small bowel with air fluid levels. So this patient, we'll skip to the chase on this one without the questions, had intussusception, and this is a common problem we see, usually idiopathic intussusception in childhood patients. What is intussusception? It's an invagination of a portion of the intestine into the lumen of the immediately adjacent bowel. And so in children and toddlers, it's usually an ileocolic intussusception where the ileum goes into the cecum. The part that goes in is the intussusceptum. The part that receives it, or the recipient, is the intussuscipens. So that is the typical appearance in idiopathic intussusception. Why does it happen? Probably has something to do with the size disparity between the ileum and the ileocecal valve, which allows for different pressure gradients to be generated and then the intussusception to occur. There's oftentimes can be a lead point. In idiopathic intussusception, it's usually this hypertrophied lymphoid tissue or pyrus patches, but it can also be a more pathologic lead point, like a Meckel's diverticulum or a polyp. Sometimes an adenoma or hemangioma, Henoch-Schönlein purpura, can cause intussusception, and in older patients, especially lymphoma, it can be post-traumatic associated with a hematoma, or it can be post-operative in patients who have had general anesthesia or a very large retroperitoneal dissection. Those patients are at risk for intussusception. It's about 1 in 4 in every 1,000 live births. There's a slight male to female predominance, more common in Caucasian patients than African American patients, and usually in patients who are at least 2 months old and up to like 4 or 5 years of age for idiopathic intussusception. Of course, patients with a pathologic lead point can have intussusception at any age. The clinical presentation starts with vomiting. It can be bilious, and that's only after it's progressed, because usually it's a distal distal obstruction from the intussusception. There can be blood and mucus per rectum, giving that, which can give that classic currant jelly stool that we see described for patients with intussusception. But that's only after there's mucosal ischemia, and so we usually don't like it to get to that point. Patients have abdominal pain that's colicky, it's intermittent. They draw their legs up to their chest characteristically, and then they have this interval lethargy because they're dehydrated and tired from having this prolonged pain. There's oftentimes a palpable abdominal mass if they'll let you examine them while they're lethargic. The right lower quadrant can be empty because the bowel migrates up to the right upper quadrant. They're often dehydrated and hypovolemic, and they can have fever and leukocytosis, and that's due to the intussusception, but also sometimes because there's an associated viral illness. Diagnosis can be made on plain films or with ultrasound or contrast enema, but really plain films, if you see it, then you can diagnose it, but you can't rule it out with plain films. Really, ultrasound and or contrast enema are your tools of choice for finding. Here's a contrast enema that shows the intussusception has made it all the way down here in the colon to the descending and sigmoid colon, with contrast outlining it more proximally. Treatment, you first want to hydrate and resuscitate the patient, oftentimes put in an NG tube. Some patients are given antibiotics in preparation of the enema because of concern for transmural migration of bacteria with the pressure. I don't personally do that, and I don't think there's a lot of evidence to support doing that for the contrast enema, but that's sometimes done. I feel like it sometimes excludes the diagnosis if we're not completely sure that it is intussusception, but usually by the time you're doing an enema, you're pretty sure. Ultrasound is very good at diagnosing it. That's the diagnostic modality of choice now because it's a lot easier and cleaner than doing a contrast enema. But the contrast enema itself can be diagnostic and then therapeutic. We will often do a hydrostatic or pneumatic reduction with column of barium. More commonly, patients or radiologists are now using an air contrast enema to reduce it, and that is a lot, again, less messy and easier to do than the liquid contrast enema. You must see reflux. Well, arguably at least, you really should, to be sure that you've reduced it completely. You should see reflux of air or liquid contrast into the small bowel when you do the enema. There's some data to suggest that because of residual edema at the ileocecal valve, that you might not see that reflux even if the intussusception is completely reduced. But certainly if the patient is still symptomatic, you're probably going to want to repeat the enema to make sure that it's completely reduced. If the enema is not successful in reducing the intussusception, then surgical reduction can be done. And that's indicated outright whenever there's peritonitis, so you're already worried about a perforation, or if there's a perforation that happens with the contrast enema, which is rare but can happen. Usually done through a right transverse incision. You want to push and not pull the intussusception apart. Really think of it as squeezing a tube of toothpaste to reduce the intussusception. You can resect if there's necrotic bowel where you can't reduce it, which is sometimes the case. And then usually an appendectomy is included. Oftentimes the appendix is pretty beat up anyway because of being involved with the intussusception. And then if it's done through a right lower quadrant incision, there's always that question, was it done for appendicitis if the patient can't remember what they had? But today with documentation being what it is, that's usually not the case. But plus or minus appendectomy, usually at the discretion of the surgeon. It's just important to document whether or not the appendix has been removed. And then the laparoscopic approach, obviously you're not going to push the bowel out with the laparoscopic graspers, but you do want to do it very gently so that the bowel isn't injured with the reduction. And it's usually pretty easy to do laparoscopically, as long as it hasn't been very chronic. Recurrence rate, a little bit higher with hydrostatic reduction, 5 to 7%, as opposed to surgical reduction down to 3%. And that's usually in the first 24 to 48 hours that we see that happen. After that, if it's ileocolic, idiopathic intussusception, usually doesn't recur. Moving on to case number 4. 2-year-old male presents to the ED after passing 2 large maroon-colored stools. He has had no abdominal pain and has a third such stool while he's waiting to be seen. On exam, he's pale and restless. Temp is 36.1, heart rate up to 160, blood pressure is low at 80/40, and respiration is 36. He weighs 10 kilos. Abdomen is soft, non-tender, non-distended. His immediate treatment should include all of the following, except placement of large bore IV access in a 200 cc bolus of normal saline, NG tube placement and gastric lavage, CBC coags, type and cross, or abdominal plain films. Yeah, abdominal plain films aren't going to help you necessarily in the short term. Really, this patient needs to be resuscitated first, and you need to do a gastric lavage to see where the bleeding is coming from. Is it upper GI? Is it lower GI? The differential diagnosis includes bleeding esophageal varices, intussusception, Meckel's diverticulum, colonic polyp, or all of the above. Right, at this point, we don't know. It could be bleeding from anywhere. Brisk esophageal varices can present with even bright red blood per rectum sometimes in young patients, and any of these other problems can present with bright red or maroon colored stools depending on where they are in the bowel. After a 40 cc per kilogram bolus of saline, his heart rate decreases, his peripheral perfusion improves, NG drainage is clear after gastric lavage, which test will most likely reveal the bleeding source. Mesenteric angio, technetium scan, EGD, colonoscopy, or CT scan. Right. For this diagnosis that we're probably all thinking of, technetium scan is the test that's most likely gonna show what this diagnosis might be. Which of the following statements regarding Meckel's diverticulum is false? They are true diverticula. Diverticulitis mimicking appendicitis is the most common presentation. Heterotopic gastric tissue is found in about 75% of symptomatic patients. And a Litres hernia is an inguinal hernia sac containing a Meckel's, which is false. Right, diverticulitis is not the way they normally present. It's usually with, that's right, bleeding. Surgical treatment of Meckel's diverticula usually occurs before age 5, can be done laparoscopically, consists of either diverticulectomy or small bowel resection, may not be indicated if the Meckel's is found incidentally in asymptomatic patients, or E, all of the above. Right, E, all of the above. All right, so Meckel's diverticulum. Who was Meckel? Johann Friedrich Meckel was alive from 1781 to 1833. He was a professor of anatomy, pathology, and zoology at the University of Halle in Germany, and described the embryological origin of this type of diverticulum named after him in 1809. It's a remnant of the vitelline duct. The blood supply from the paired vitelline arteries during embryogenesis originate both from the aorta. The left vitelline artery involutes, and the right vitelline artery then persists as the SMA. And thinking back to that diagram I showed you of the developing bowel loop during the malrotation portion of the lecture, that SMA is the blood supply for the entire midgut as it develops and it continues to grow, and that little outpouching is the Meckel's. The vitelline duct usually involutes by week 8, but if it's persistent, it can result in a multitude of different pathological lesions. There can be an umbilicointestinal fistula, an umbilical sinus, a little subumbilical cyst, a remnant band, or a Meckel's diverticulum. And I'll show you some pictures of those. The rules of 2 that we all think about with Meckel's diverticulum, it affects 2% of the population. Male to female predominance is 2 to 1. More than half present before age 2. It's about 2 inches long in most cases. It's within 2 feet of the ileocecal valve. Contains 2 types of ectopic mucosa, gastric or pancreatic, and about 2% or up to 5% lifetime risk of complication exists for patients who have Meckel's diverticulum. And here, this is a plate from Dr. Ladd's textbook that described Meckel's diverticulum, and it shows the different types of complications. There can be obstruction from a band. This is the abdominal wall, and this is the Meckel's here, and there's another loop of bowel that's obstructed, creating an internal hernia. You can have a fistula at the umbilicus from a persistent tract. There can be ulceration with hemorrhage, which is, again, bleeding, the most common presentation for Meckel's, where you have ectopic gastromucosa that secretes acid and causes ulceration with hemorrhage into the distal bowel. There can be a diverticulum with or without perforation. There can be intussusception with the Meckel's as a lead point, or you can have twisting and infarction of the Meckel's diverticulum itself if it becomes large. Again, diagnosis with a Meckel scan or a technetium-99 scan that shows abnormal uptake. This is this little dot in the right lower quadrant here on this patient. There's uptake in the stomach as well as in the bladder, but because of the gastric mucosa in the Meckel's, you can see there's some uptake in that spot. Management, if patients are symptomatic, they usually undergo diverticulectomy versus small bowel resection. Most of the time, diverticulectomy is sufficient if there's extension of ectopic mucosa into the adjacent small bowel, or certainly if there's a bad ulceration with ongoing bleeding, then the adjacent small bowel can be resected. If it's found incidentally, again, lifetime risk of complications is 2 to 5%. Factors predictive of complications: age less than 40 years, presence of heterotopic mucosa, which you can really palpate inside the Meckel's. If it's lumpy, when you feel it, there's usually ectopic mucosa. Or if it's long, if it's more than 2 centimeters, more than 1 inch in length, then those patients have an increased risk of complications. And we usually recommend resecting them in pediatric patients, certainly if it's attached to the anterior abdominal wall, like that one diagram, which can create a band, placing patients at risk for an internal hernia, or if there's unexplained abdominal pain for a patient and it's found, then we usually recommend resecting the Meckel's. And there's just a picture of a Meckel's. This is the small bowel, and this is the Meckel's here. All right. Moving on to case 5, 12-year-old female, 48 hours of abdominal pain, 1 episode of vomiting, which was just food, no bile. Patient had diarrhea, then no bowel movement for 24 hours. The whole family had food poisoning 2 days ago. Pain began in the middle of the abdomen. Now it's more on the right side. So what is this? It's appendicitis. And I had to put this in here. I know you all know how to manage appendicitis, but it's the most common surgical emergency that we deal with as pediatric surgeons. And it's really the most common surgical condition of the abdomen. There's about 250,000 cases each year in the U.S. 70,000 of those patients are children. There's a slight male to female predominance. Lifetime risk for appendicitis, probably 9% in males, 7% in females. Most common in the 2nd and 3rd decades of life. There's a slight summer predilection, and then perforated seems to be more common in the winter. Unclear why this happens. The pathophysiology, just to review, there's luminal obstruction of the appendix for some reason, sometimes with a fecalith, but oftentimes just with lymphoid hyperplasia after a viral gastroenteritis or any type of viral infection. There's continued mucus secretion within the appendix. That leads to dilation of the appendix, obstruction of the lymphatics, increased edema of the appendiceal wall. Then you get visceral referred pain to the T10 dermatome, which gives you that periumbilical pain, which results, following the edema, then results in venous obstruction, which then leads to arterial ischemia, localized peritonitis with mucosal, and then serosal ischemia, which leads to perforation and then diffuse peritonitis if it gets to that point. So we try to treat it before that. Pain is usually the first presentation. If there are GI symptoms before pain, then we consider alternative diagnosis, but patients can present really with any or all of these symptoms, or sometimes none of them, and still have appendicitis. The pain is usually periumbilical, then localized to the right lower quadrant, is localized at McBurney's point, which is a point 2/3 lateral between the umbilicus and the anterior superior iliac spine. If the appendix is retrocecal, there can be back or flank pain, and the psoas or obturator signs can be indicative of that. There can be anorexia, nausea, vomiting, constipation, diarrhea, or any spectrum of those types of symptoms. There's usually a leukocytosis and an elevated CRP or ESR. Plain films can show a fecalith, obliteration of the psoas shadow, lumbar scoliosis away from the lesion, and then chest x-ray is important to rule out pneumonia. Patients with right lower quadrant pain can oftentimes have a right lower lobe pneumonia, which should be ruled out. In female patients especially, you want to make sure that they don't have other confounding diagnoses such as pregnancy or ovarian torsion, cyst, ovarian mass, pelvic inflammatory disease, vaginal foreign body, or vaginal trauma. So getting an ultrasound to diagnose appendix is also helpful in looking at the adnexal structures, especially in female patients, to rule out some of those other problems. But if there is appendicitis, there can be free fluid seen on ultrasound. The appendix is often 7 millimeters or greater in diameter, indicating that it's dilated, and oftentimes you can see a fecalith. And the appendix on ultrasound is oftentimes non-compressible, which is another characteristic. If a patient has a CT scan, the appendix is dilated, doesn't fill with contrast, there can be free fluid and fat stranding around the appendix, all indicating inflammation, and if it's perforated, obviously an abscess. So here's just a plain film that's showing an appendicolith down here in the center. So a patient with right lower quadrant pain, fever, leukocytosis, and a plain film that shows this in the presence of right lower quadrant pain really should be appendicitis until proven otherwise. You don't need a CT scan to take that patient to the operating room. Here's another finding of appendicolith. So really some value still in plain films occasionally. Here's an ultrasound of appendicitis, a dilated appendix measuring more than 7 millimeters. It's not compressible. You can see the normal caliber here of the appendix, and this is really the tip of the appendix, which is dilated. Pretty easy to see in this patient. And then on CT scan, even a better image. You can see the small bowel filling with contrast normally, but here's the appendix. It doesn't fill with contrast. Here it is in the coronal sections where it's long and dilated. Really pretty indicative. There's some fat stranding around it, indicative of appendicitis. So we would hydrate these patients. We treat them with antibiotics. In pediatric patients, we really haven't gotten to the point where we're treating appendicitis solely with antibiotics and without surgery. The data is not yet sufficient to support that treatment modality, basically because of the risk for lifetime recurrence of appendicitis. And so really still surgical resection of the appendix is recommended in pediatric patients, either with open appendectomy, more than likely laparoscopic appendectomy in most places, and sometimes if they have perforated appendicitis, we'll do drainage of a pelvic abscess and then interval appendectomy to allow for resolution of the inflammation and then safer removal of the appendix with less risk of complication of injury to adjacent structures. Quickly moving on to case 6, 2-month-old infant male presents to the ED with lethargy. The baby fed well, taking in 4 ounces of formula before she left him with her boyfriend while she was out buying formula for the baby. When she checked on him 4 hours later, he was difficult to arouse. On exam, the baby appears lethargic with shallow breathing, is a little bit hypothermic, tachycardic, hypotensive, but seems to be satting okay on room air. So the next best step in management would be blood cultures and IV Zosyn, placement of large bore IV access and more mycetonic crystalloid, transfused 20 cc's per kilo of packed blood cells, abdominal plain films, or CT head. And I already clicked on it a little bit early there, but really, no matter what this patient has, and I think we're all thinking what it might be, but really, resuscitation is most important. And if this is any kind of trauma, the ABCs, airway breathing seem to be intact, but the patient is hypotensive, tachycardic, so you really want to support him with an IV fluid bolus to start with. Really child maltreatment, one of the really sad parts about pediatric surgery, but something we all have to think about. If we don't keep the possibility of this diagnosis at the forefront of our mind, we'll miss it every time. Definitions of abuse: there could be physical abuse, beating, shaking, scalding, biting, also neglect with omission of care, omission of education, supervision, disregard for protection from environmental hazards. So lots of neglect types of abuse too. And this is the data is a little bit old, but it unfortunately hasn't changed very much recently. Almost 450,000 sustained cases or substantiated cases of maltreatment in the U.S. in 2010. The majority of those were from neglect, but a fifth of them almost physical abuse, and then 10% almost sexual abuse. Almost 700,000 victims in the U.S. Victims aged from birth to 1 year have the highest rate of victimization. It's about 20 per 1,000 children of the same age group in the national population. So unfortunately, way too common. Almost a 50-50 male to female ratio in terms of who's affected the most. 80% of the victims were either African American, Hispanic, or white, with white Caucasian patients being the highest group. 1,500 children in 2010 died from child maltreatment. It's 2 deaths per 100,000 children, and almost 80% of those child fatalities were in patients younger than age 4. So really the youngest patients being the ones most at risk. Clues about abuse. We should have a red flag in our minds whenever there's a discrepancy between the story and the degree of abuse. If there seems to be a delay in the presentation, repeated trauma in the same or different emergency departments, story changes between parents and guardians, history of changing doctors or hospitals, or parents seem to respond inappropriately when questioned. Multicolored bruises, old scars, healing fractures, perioral injuries, perineal injuries, and long bone fractures in children less than 3 are physical exam findings that suggest abuse. On imaging, ruptured internal viscera without a story of trauma, multiple subdural hemorrhages without skull fracture, retinal hemorrhages, bites, cigarette burns, rope marks, sharply demarcated burns or bruises are all signs of physical abuse. Other findings on imaging that are found characteristically in patients who have been abused: pancreatic injury, hollow viscous injury, traumatic brain injury, as well as young age, poor nutrition, and neglect are characteristics of patients seen for abuse. Children with abdominal injury seem to have the higher mortality rates than patients with non-abusive injuries of the same severity. So if they're being abused and have an injury, those patients tend to do worse than patients who have the same injuries, so to speak, who were not abused and received trauma for other reasons. And diagnostic delay may contribute to those poor outcomes. So history is a very important part of the diagnosis. If there's an absence for explanation of the injury, changing explanations inconsistent with the child's developmental capabilities, such as a 1-month-old that rolls off the bed, or if there's a delay in seeking medical care. Details in the history should include previous trauma, admissions to hospital, chronic illnesses, adherence to treatment once they're seen and evaluated, in a family history of easy bruising or fractures, which may give rise to certain genetic disorders that might exist. We should always ask about substance or alcohol abuse in the family, mental illness, intimate partner violence, discipline practices, stressors, previous involvement of child protective service, and careful documentation with photographs of the injuries when patients are seen. And a lot of our screening tools that we use, especially in the emergency room now, are looking for these types of things, so they're really missed a lot less than they used to be. Abdominal trauma accounts for a substantial morbidity and mortality in abused children. That's probably because they have large abdomens, they're easy targets, there's lax abdominal musculature, and a small rib cage, which doesn't protect the intra-abdominal organs, as well as older children and adults. The bruising of the abdominal wall is unusual. There's a very effective transference of force to the underlying viscera. Perforation can be delayed for days after injury, and pancreatic pseudocysts can occur even weeks to months later, so very remote from the actual injury. Hollow organs can be ruptured by a blow or a kick. Solid organs can be injured where they contact the spine. Bleeding can result from trauma of any organ or shearing of the vascular supply, and bilious vomiting in a child without fever or peritoneal irritation suggests possible duodenal hematoma, which can be incurred with abuse. On physical exam, the classic signs and symptoms of abdominal tenderness, bruising, or distension can be unreliable, as we talked about, especially in very young patients. And lab tests that we look at in older patients, like amylase, lipase, transaminases, are really of questionable utility in all patients, but especially in the youngest patients. So we rely a lot on the history and then our radiographic evaluation. Skeletal survey is important to look for other signs of bony injury, bone scan, and then our axial imaging of CT, MR, and ultrasound. Ultrasound is highly sensitive for the detection of intraperitoneal fluid, but actually looking for the organ injuries, it's not so effective still, and it is getting better. But in hemodynamically stable patients, the value of ultrasound is limited by the large percentage of organ injuries that don't associate with free fluid. And so the AAP recommendations in 2009, although we really try to avoid the use of CT scan and radiation exposure in patients, in young patients, we still believe that CT scan is probably the best imaging modality choice for evaluation of thoracoabdominal injuries. And then upper GI can be used really to look for a duodenal injury that might be missed otherwise. This is an important public health concern, and visceral injuries can vary, but present with recognized patterns that we looked at. And it's really important to have a multidisciplinary approach from multiple people along the both the intake and treatment pathways in our hospitals and institutions to look at age, mechanism, type of injury to really arrive at an accurate diagnosis. We have to be aware of the limitations in the diagnostic methods, and really prevention is key. So identifying at-risk patients and at-risk families and helping them to avoid presenting like this. So case 7, 10-day-old, 27-week gestation infant male is in the NICU, intubated since birth on physiologic vent settings, getting fortified breast milk feeds to 24 kilocalories per ounce via a nasogastric tube. You're called to see him for increased abdominal distension and bloody stools. On exam, he's markedly distended and appears tender to abdominal palpation diffusely. And this is the patient on exam, markedly distended, shiny red abdomen, obviously something going on there. Proper management of this patient includes making him NPO, placing a nasogastric sump tube to suction, CBC and blood cultures, broad spectrum antibiotics, abdominal plain films in 2 views, or all of the above. Really all of the above would be useful in this patient. So GI bleeding, which is one of the points of this patient's history, but I wanted to look at this from a more of a broad presentation standpoint to look at a bunch of different types of diseases that we see in pediatric patients that can be surgical. Just to illustrate the fact that it can be age dependent. The first thing you need to determine in GI bleeding, as we all know, is it upper, is it lower, is it surgical, is it non-surgical? Those are really the key questions to ask anytime you're seeing a patient with a GI bleed. But thinking about it with respect to the patient's age will help to arrive at a more well-defined differential diagnosis. So the diagnosis can vary whether the patient's neonatal, are they 1 month to 1 year, 1 to 2 years, or greater than 2 years. So on neonatal patients, the upper GI sources of bleeding most commonly can be from swallowed maternal blood, especially if they're always really if they're nursing. That can oftentimes there can be some bleeding from the mother's breast, and that can result in a seeming GI. It might seem to be a GI bleed, but really isn't. There can be gastritis and then some undiagnosed coagulopathy. Lower GI bleeding is most commonly from anal fissure, sometimes necrotizing enterocolitis, and rarely, but sometimes malrotation with volvulus if it's progressed to ischemia. It's more common in premature or distressed infants if there's a stressful birth with low APGARs or some sort of fetal stress prior to delivery, or if the delivery is complicated by a nuchal cord or meconium aspiration. If the patient requires aggressive resuscitation, has low APGAR scores, if they can have coffee ground gastric aspirate or even melena. Those types of findings are usually how patients will present. We usually will start by giving the patient vitamin K to help with their coagulation, check their coagulation factors. Usually do place an NG tube, do a gastric lavage, place the NG tube to suction, and then start an H2 blocker or PPI, especially if it's gastritis. Peptic ulcer disease in a neonate is really rare. It can be really diagnosed most definitively by doing upper endoscopy, and these patients are placed on acid blockade. And then really, if they're having neonatal peptic ulcer disease, they need to be evaluated for disorders of gastric acid secretion like Zollinger-Ellison syndrome. One of the most common sources of bleeding in an infant is an anal fissure. Usually presents with some bright red blood seen in the diaper or streaks on the stool. It's diagnosed on a physical exam. You really have to look for it and have to be careful not to cause a fissure when you're looking at baby's anus, because it can be very delicate to look at that site. But with careful gentle evaluation, a fissure can usually be diagnosed safely. And those patients sometimes respond to rectal dilation, but usually just to conservative measures. We don't dilate patients unless we're worried they have some sort of rectal stenosis. Necrotizing enterocolitis, which is where our patient in the case had, must be suspected given the history and risk factors. Usually patients who are premature, oftentimes on fortified or formula feeds, who have had some sort of, oftentimes some sort of stressful neonatal course, either with hypoxia, sometimes with maternal cocaine use, or sepsis. Those patients are at risk for necrotizing enterocolitis. They're usually distended, they have thrombocytopenia, they have pneumatosis or free air seen on X-ray if it's progressed to that point. Usually we treat those patients unless they have perforation with antibiotics, bowel rest, and TPN. If they have perforation, they sometimes require laparotomy versus drainage, resection of bowel, and decompression. Recurrent bleeding can, after treatment for necrotizing enterocolitis, can signal recurrent necrotizing enterocolitis or sometimes a stricture that's resulted from necrotizing enterocolitis. So here's just some pictures of pneumatosis. In an older patient, we might think that this bubbly pattern within the distribution of the colon might be stool, but in a patient with dilated bowel, who's a neonate and who is maybe distended and having bloody bowel movements, that's pneumatosis until proven otherwise. And here it is a little bit more dramatically. You can really see the distinct air within the wall of these bowel loops in multiple places. And this patient had really severe necrotizing enterocolitis. Here's a patient that on cross-table lateral is seen to have some free air in the anterior abdominal wall here. So that patient has a perforation. That's really the only indication to go to the operating room with necrotizing enterocolitis is perforation. Most other findings and patients with necrotizing enterocolitis can be treated at least initially with antibiotics and bowel rest, and sometimes don't require surgery. In fact, most of the time don't require surgery. They only do if they have persistent symptoms, fail to progress, or then go on to develop perforation. Here's a patient with necrotizing enterocolitis, just some focal areas of necrosis and pneumatosis that's kind of more grossly seen within the bowel wall here. This is a patient after having really terrible necrotizing enterocolitis where some bowel was resected and things didn't heal properly. They ended up having multiple areas of basically enterocutaneous, enteroatmospheric fistulas with exteriorized bowel loops. And this is what can happen after severe necrotizing enterocolitis in a very complicated patient. So you can just imagine how difficult this is to put back together. Malrotation of midgut volvulus rarely presents with a GI bleed, but there can be some melena if the patient has mucosal ischemia. And we've already talked about this. They have progressive abdominal distension sometimes and sometimes not, tenderness, and if they're stable, we do an upper GI. If we find there's malrotation or if they're unstable, we go right to laparotomy and LADS procedure. In patients 1 month to 1 year, the upper GI sources start to include things like esophagitis, hypertrophic pyloric stenosis, and gastritis. lower GI sources of bleeding, anal fissure again, intussusception, or bowel ischemia. Esophagitis usually can be associated with severe GERD or gastroesophageal reflux. Those patients, you might want to do an upper GI contrast study to look for areas of inflammation. Esophagoscopy and pH monitoring would be more of the definitive test. Sometimes we do a manometry or sometimes a technetium scan with modified barium swallow to look at the swallowing mechanism and to help diagnose reflux. Those patients can usually be treated medically. Most patients will grow out of reflux with medical management of acid secretion, thickened feeds, upright positioning after feeds, sometimes prokinetic agents like erythromycin or Reglan, and then if they still are not responding, a surgical anti-reflux procedure is sometimes needed. Pyloric stenosis almost never presents with bleeding, but sometimes patients, if they have severe enough vomiting, can have some blood in the vomit, so it's on the differential. But usually these patients have a history of progressive feeding intolerance and forceful, quote, projectile emesis that's usually not bilious, not bloody. If they're lethargic enough, you can sometimes palpate the hypertrophic pylorus, which feels like an olive in the epigastrium. The ultrasound is really the diagnostic method of choice for these patients and has become a very good way of making this diagnosis much earlier than we used to. So patients are much less dehydrated, much less in extremis than they used to be, and we will then proceed with usually laparoscopic pyloromyotomy. Intussusception, we already talked about. Vomiting that can be bilious, recurrent episodic abdominal pain, current jelly stools. We do an ultrasound and then a contrast enema, hydrostatic reduction versus surgical reduction. Only results in a GI bleed if it's gone on to progress to mucosal ischemia. And here's just an intussusception that was found and corrected laparoscopically. You can see the bowel, the proximal bowel going into the distal bowel segment here. In patients 1 month to 1 year, we start to think about bowel ischemia as a possible diagnosis. Patients can have a volvulus, which can be either midgut or segmental. They can have volvulus around the non-phallomesenteric duct remnant or like an extension of the Meckel's diverticulum that we talked about before. They can have an internal hernia. And those patients, if they have ischemic bowel, they're going to present with dehydration, shock, and then maybe signs of peritonitis and perforation. Plain films can show free air. Oftentimes now, CT scan is used is usually the test that will diagnose bowel ischemia. We can see findings suggestive of ischemia like pneumatosis in older patients. Endoscopy, usually not, and then certainly they may require an exploratory laparotomy for both diagnostic and therapeutic purposes. And here's just an example of a Meckel's with an ileal fistula that occurred with an internal hernia in between, and this patient had a bowel obstruction, and unfortunately not ischemia, but that's just an example of how an internal hernia can occur with a Meckel's diverticulum. Once we get to patients who are 1 to 2 years of age, we start to think more about peptic ulcer disease as a source for GI bleeding, and then things like polyps and a Meckel's diverticulum in the lower GI tract. Peptic ulcer disease in these patients will have associated conditions, sometimes associated with trauma or burns, sometimes with malignancy or sepsis. We want to test for H. pylori in these patients. Usually these patients will go on to have endoscopy, gastroenterology. They'll be started on anti-acid therapy. And then we want to fix the underlying problem. If it's H. pylori, they could treat it for H. pylori. If there's an ulcer, we work that up. And then usually surgery not necessary, but only in extreme cases. Polyps, they're usually the juvenile type in this age group. They can sometimes be throughout the colon, but sometimes in the small bowel, things like Peutz-Jeghers, as well as juvenile polyposis, can have isolated polyps. These patients will have painless blood-streaked stool, sometimes more vigorous blood per rectum. They can have what is diagnosed as rectal prolapse, but oftentimes just a juvenile polyp that's protruding in and out of the anus. So physical exam is important. Enema or endoscopy can be both diagnostic and therapeutic. the endoscopy, of course. And then if there are many polyps, then obviously you want to consider, does that patient have familial adenomatous polyposis coli, and do they need to be evaluated and managed from a genetic standpoint? Meckel's diverticulum, we already talked about. Painless, brisk red blood per rectum. Meckel's scan will help diagnose it, and rules of two, and then diverticulumectomy versus bowel resection in those patients. Once we get over age 2, we start to think about things like esophageal and gastric varices, if there's a brisk upper GI bleed, lower GI bleed, again, polyps. We start to think more about inflammatory bowel disease, trauma, and other sources of bleeding. Varices, fortunately rare in pediatric patients. Usually these patients will have portal venous thrombosis for some reason, usually from liver disease. Usually they're being already watched for because of their other underlying problems. Do they have cirrhosis? If they progress to cirrhosis and have variceal bleeds, then those patients are going to be usually being evaluated for transplant. Older patients will have polyps just like younger patients, but also we start to think more about inflammatory bowel disease, Crohn's disease, ulcerative colitis in sometimes very young onset. Patients will present with bloody diarrhea and need to be evaluated for inflammatory bowel disease. Henoch-Schönlein purpura can present with bloody bowel movements. We start to think of AVMs, arteriovenous malformations within the bowel wall, which can be localized on bleeding scans. Hemangiomas, sometimes duplications, intestinal duplications can present with bleeding. And then foreign bodies we start to think about that were either ingested or inserted can cause bleeding in these older age groups. And here's just a finding of Crohn's disease in a young patient, where you can see the creeping fat from the mesentery onto the serosa of the bowel wall, which can mimic appendicitis with right lower quadrant pain. So always should be on the differential for right lower quadrant pain, and also for older patients who are having GI bleeds. So really, key points for patients, pediatric surgical patients, bilious emesis should always be thought of as a sign of obstruction, but more importantly, malrotation with midgut volvulus. Bilious emesis should automatically make one think of malrotation with volvulus, which, if it exists, is really one of the few true pediatric surgical emergencies. The differential for most diagnoses, especially GI bleeding, can vary with age, and kids are not just little adults. So there are a lot of differences, some of which we talked about today. So thanks for your time. I hope this was helpful, and please feel free to contact me with any questions.